Look, I can tell you're really excited to get into renal pathology. It's like one of the kids' meals at Mega King Burgers. You just want to jump straight to that toy. I don't blame you. They've got the entire new line of Jurassic Park toys, just in time for the movie release. Yeah, but hang on a second. Before getting into renal pathology, you've got to master some good old-fashioned renal function testing and lab values. It's okay. We'll make it easy. First, we'll cover routine measures of renal function, like BUN and creatinine, and then look at how things change in the setting of acute kidney injury. One of the main players here is creatinine, and at Sketchy, it's always represented by a creatinine credit card. Creatinine is the breakdown product of creatine. See how you can create your own creatine value meal? Well, let's see what options we have to the right there. Got some meat, another meaty thing, a gross-looking meat kebab or something. Yep, creatine is in your meat, which, when phrased less awkwardly, means that creatine is a molecule that lives inside muscle cells, holding onto high-energy phosphates to help generate ATP during muscle contraction. When it's broken down, it ends up in your blood as creatinine, which we can measure. Creatinine has a normal serum concentration of 0.6 to 1.2 milligrams per deciliter. You can usually expect to see a value around 1.0, hence the dollar menu sign up above. Why is creatinine so important in renal physiology, though? Well, it actually has nothing to do with creatinine itself. Instead, what's important here is the way it's filtered by the kidney. Creatinine floats around in your blood, ends up at the glomerulus, and from there, it's freely filtered into Bowman's capsule and right on into that renal tubule. In other words, the concentration that reaches the glomerulus is the same that enters the nephron for excretion. Just think of this display of free filtered water. That means freely filtered. Also, once creatinine is in the tubule, the nephron doesn't do much to it. The concentration that enters your nephron is pretty much the same as the concentration that leaves the nephron and enters the urine. So don't worry, it's neither secreted nor absorbed by the nephron. It just passes on through. Psst, hey, it's actually secreted a little tiny bit into the nephron, so the urine may be slightly more concentrated than the blood. All right, let's back up a bit. So, for creatinine to go from blood to urine, it needs to be filtered from the glomerulus to Bowman's space in the nephron. The rate at which this occurs is called glomerular filtration rate, or GFR. It's essentially the amount of fluid that filters into Bowman's space per unit time, which directly affects the rate of clearance of substrate from the serum into the filtrate. At Sketchy, GFR is represented by the rate of a coffee filter, the ground's filtration rate, if you will. Now, when I say GFR, you might just think of a single nephron. In reality, though, the total value of GFR is equal to the sum of the filtration rates in all of the functioning nephrons. When added together, glomeruli filter about 180 liters of fluid per day. That's about 125 milliliters per minute. When the kidney isn't functioning, it's not filtering, and GFR goes down. So that sounds like something important I want to measure, right? Well, too bad. Measurement of GFR is complex, time-consuming, and cumbersome to do in clinical practice. Instead of assessing GFR directly then, let's estimate it with serum markers. You'll hear people call this estimated GFR, or eGFR. One way to do this is to choose a molecule and measure how fast it's being cleared from the serum. An ideal filtration marker would be a solute that is freely filtered at the glomerulus, and once it's in that nephron, neither secreted nor reabsorbed. Wait, that sounds like creatinine. Let's just use that. So we assess creatinine clearance to estimate GFR. Take a look. Next to our GFR coffee, we've placed a credit card getting cleared to remind you that creatinine clearance kind of approximates GFR. Hey, it's actually secreted into the renal tubule just a little bit, remember? So it will actually overestimate GFR. It'll be our little secret. Inulin is actually a much better molecule to use. However, it has to be injected into your patient. Why not just use creatinine then? It's already floating around in your patient's serum. An approximation of GFR is pretty darn close. The specific equation used to calculate creatinine clearance is incorporated into the sign that directs patrons to the extra cups. You see it? C equals UV over P. That arrow is a V, by the way. C is for clearance. Clearance of creatinine is equal to the urine concentration of creatinine times the volume of urine excreted in 24 hours, divided by the plasma concentration of creatinine. A normal value for creatinine clearance is about 100 to 140 milliliters per minute. Remember, though, this is a slight overestimation of GFR. Nevertheless, it's safe to say that values over 100 are pretty good, so we've incorporated the number 100 up above. In general, a creatinine clearance under 100 milliliters per minute is abnormal, and a value less than 10 milliliters per minute indicates renal failure. Oh, and just so you know, this renal clearance equation is good for any molecule that's filtered by the kidney. Just plug in its concentration values. Clearance will approximate GFR, however, only if this molecule is freely filtered and neither secreted nor absorbed by the nephron. As with any renal measurement, there are several things that can influence the value. And it's one of the reasons why clinicians don't really use the C equals UV over P equation. Instead, there are calculators that take into account body mass and age, and sometimes even gender and race. All kinds of stuff. One of the most important factors that you should keep in mind is patient age. Creatinine clearance, and therefore GFR, decreases by about 1 milliliter per minute per year after age 50. Your kidneys just don't want to filter stuff anymore. They get tired, okay? This is represented by the old man behind the counter, as he sends that GFR coffee plummeting to the floor. As a result, extra careful dosing procedures are used in the elderly, especially when you're administering a drug that's exclusively cleared by the kidneys. In the setting of decreased GFR, the drug is going to stick around in the patient's serum for a lot longer than you think. It's time to talk about another important component of the renal filtrate, blood urea nitrogen, or BUN. At Sketchy, whenever we discuss BUN, we'll use a hamburger bun, just like the one on this fast food bag here. What is a BUN, though? And does it come with cheese? Well, it's all in the name. Blood urea nitrogen. Blood, which means it's measured in the serum, and urea nitrogen, as in, urea, the final breakdown product of nitrogen-containing compounds excreted by the kidney. This blood urea nitrogen comes from the urea cycle, for example. See the cycle of order receipts marked with the letter N? This is how amino acids are broken down in the liver. Pyrimidines, those hexagon-shaped nitrogenous bases in DNA, are also metabolized to urea before being excreted by the kidney. Hence the pyrimidine-esque tiles in the back there. A normal value ranges from about 7 to 20 milligrams per deciliter, so look for values around 10. Order up! Numerous factors can contribute to increased or decreased BUN. Liver failure, for example, means no urea cycle. No urea cycle means a decreased BUN. And I can increase BUN by, something as simple as increasing my protein intake. Remember that amino acids are turned to urea. In this scene, however, we're going to be looking at how kidney dysfunction affects BUN. Urea is filtered by the kidney, so any cause of declined renal function, in other words, a decrease in its filtering ability, or GFR, will cause BUN to build up in the serum. One last thing to mention. Blood urea nitrogen does not just pass on through the nephron like creatinine. Once it's filtered at the glomerulus, a lot of it is reabsorbed at the proximal convoluted tubule. In Sketchy Farm, the proximal convoluted tubule was the pro-car track, so we've brought it back here. Look at this guy. He probably gets asked on a date like 5 times a day. Pfft. Sorry, ladies. I'm busy tonight. Getting another free t-shirt at a monster truck rally. Alone. No, that wasn't somewhat autobiographical? Moving on. See how that BUN bun grease lands right on his shirt and is reabsorbed? That's where urea is reabsorbed, at the proximal convoluted tubule. This will come into play a bit later. But first, a brief recap. GFR tells us how well our kidney is functioning, but we usually only estimate this value. One way to estimate GFR is to look at creatinine clearance, or how much creatinine is removed by the kidney in 24 hours. It's that funky C equals UV over P equation. In the setting of decreased GFR, both creatinine and BUN aren't cleared as well, so they accumulate in the serum. Remember that serum creatinine usually sits around 1 milligram per deciliter. Hence the $1 menu, so look for it to be increasing from there. BUN values are usually around 10 milligrams per deciliter, as depicted by order number 10, but look for it on the rise. Increased BUN and creatinine is what we call azotemia, and for the remainder of this sketch, we're going to look at 3 different scenarios that cause acute renal dysfunction, leading to a measurable azotemia. The lesion can occur before the kidney, right inside the kidney, or distal to the kidney, in the urine collecting system. This is dubbed prerenal, renal, and postrenal azotemia, depicted by a BUN bun and creatinine credit card. To the left of the booth, inside the booth, and after the booth, respectively. When this azotemia occurs in the acute setting, regardless of whether it's prerenal, renal, or postrenal, we call it acute kidney injury, or AKI. Just think of the AKI in Mega King burgers. For a more strict definition of AKI, clinicians look at 2 things: an acute rise in creatinine or a low urine output, also called oliguria. These 2 things are great for telling us how our patient's GFR is doing. So, next to our AKI logo, we've included a creatinine credit card along with an oliguric-looking cup, barely mustering a small trickle there. When you're on the wards and your attending asks you how the patient's kidneys are doing, you better at least have some idea of recent changes in serum creatinine and urine output. There are a lot more labs to look at, however, that can really help us narrow down whether the AKI is prerenal, renal, or postrenal. Let's start with pre-renal AKI. How is it that a lesion proximal to the kidney is causing acute kidney injury? We haven't even reached the organ yet. Well, it most often occurs when not enough blood reaches the kidneys, as is the case in hypovolemia or hemorrhage. Just look at this hemorrhage of ketchup here. There's not going to be much left for kidney perfusion. The same is true in low cardiac output states, like congestive heart failure, as depicted by our recurring floppy heart failure balloon. Again, the kidney is hypoperfused. It's just not this guy's day. So, if the kidney receives less fluid, it doesn't filter as much fluid, causing BUN and creatinine to accumulate in the serum. That's what we call prerenal azotemia. We don't just look at the absolute values, however. The BUN creatinine ratio is important as well, and here's why. Remember that BUN is actively resorbed at the proximal tubule. Well, this process is increased during low perfusion states. The kidney senses low volume, so it assumes that the body needs to conserve water. To help out, it ramps up urea resorption, because urea is integral to the countercurrent exchange system in the kidney that powers water conservation. See how all that BUN bun juice is getting absorbed in her shirt there? That means urea conservation. So, to put it simply, in low flow states, yes, BUN and creatinine are elevated, but BUN is really elevated. So the BUN creatinine ratio is high, somewhere above 15. Whenever we want to show an elevated ratio specifically, that BUN bag will be raised in the air above that creatinine credit card. Another value clinicians use to assess prerenal AKI is the fractional excretion of sodium, abbreviated as FeNA. A high FeNA means that lots of sodium is getting excreted. A low FeNA means that we are conserving sodium, reabsorbing it at the nephron. Well, at the heart of prerenal AKI is decreased perfusion. So the kidneys will activate the renin-angiotensin system and, as expected, try to conserve sodium, because when you conserve sodium, water follows. The FeNA will therefore be less than 1%, reflecting increased sodium reabsorption. Just think of one of these salty FeNA fries falling to the floor. If we show 1 tray of fries falling, that means FeNA is less than 1%. The exact equation used to calculate FeNA is UP over UP. It involves urine and plasma concentrations of sodium and creatinine. See the equation on her trendy Up and Away brand name shirt? A perfect match for those cool navel-high cutoff short jorts. Looking good. Anyways, this is less important than just knowing that FeNA is less than 1% in pre-renal AKI. Urine sodium can also be measured, and it goes hand in hand with FeNA. If you're conserving sodium, you can bet you're going to see a low urine sodium, usually less than 20 milliequivalents per liter. Don't worry about that value though. They'll always give you a normal range to compare it to. What's more important is knowing that we're reabsorbing sodium, leading to low FeNA and low urine sodium values. With all this water conservation going on, the urine will also be concentrated. Urine concentration is measured in osmoles and is abbreviated UOSM. Take a look over at the con-osm to see what I mean. Notice that the pepper is knocked over and really concentrating that mustard. In pre-renal AKI, look for a UOSM greater than 500. Again, they'll likely give you a normal range to work off of. Just remember that we're concentrating urine here and preserving volume. All right, let's move over to the booth, where we'll illustrate all that is intrinsic AKI. Intrinsic means we're doing some kind of damage directly to the kidney. This most commonly takes the form of acute tubular necrosis, or ATN, a condition that involves death of renal tubular cells. At Sketchy, this acute tubular necrosis is represented by a puddle of necrotic, muddy-looking fluid spilling out of a tube. Kinda like this chocolate milkshake, dribbling out of the straw there. It evokes the characteristic muddy cast seen on urine sediment, and we'll get into much greater detail in our next video. Another intrinsic cause of AKI is acute interstitial nephritis, or AIN. It's always represented by a bunch of blue spots filling a kidney in order to convey the inflammatory cells invading the interstitium that you can see on histology, all those little blue nuclei. Glomerulopathies are another etiology to consider here. A red, leaky, curly straw? Yep, that's glomerulonephritis for you. Regardless of the cause, tubular dysfunction and decreased filtration means there will be a backup of both BUN and creatinine in the blood. Hence our BUN bag with the creatinine credit card. This is what they mean by azotemia, by the way. Unlike last time, however, the ratio of BUN to creatinine will not be super high. Remember, for the ratio to be high, we need BUN to be actively reabsorbed at the proximal tubule. In the setting of intrinsic renal injury, however, the kidney just isn't good at reabsorbing stuff anymore. So BUN is elevated, but it's not like, holy crap, that bun is high. It's more like, oh, BUN and creatinine are elevated. My interest is somewhat piqued. Specifically, the ratio tends to be less than 15. That's why we're not raising that BUN bag up in the air, like last time. We can look at FeNA again, too. Low FeNA means lots of sodium retention. High FeNA means lots of sodium excreted. Now, it's your kidney's job to actively reabsorb sodium. Check out our Sketchy Farm diuretic chapter to see all the places in the nephron where this occurs. At any rate, because we have intrinsic damage to those tubules, we can't reabsorb, and lots of sodium is excreted. That leads to a FeNA of greater than 2%. In this scene, 2 trays of salty FeNA fries lifted up means that FeNA is over 2. Again, urine sodium goes hand in hand with FeNA. Urine sodium will be high, as all that sodium is wasted by the kidney. Specifically, it'll probably be somewhere greater than 40 milliequivalents per liter. But just remember that it's elevated. What about overall urine concentration? It's measured as UOSM, remember? It turns out that UOSMs will be low this time. And we tried to represent this with an empty con-osm bottle, unlike the overabundance of condiments happening to the left there. The reason why intrinsic kidney injury leads to more dilute urine is this. The kidney is not just responsible for reabsorbing sodium. One of its main goals is to decide how much water to hold on to as well. A busted kidney is a sad kidney. And a sad kidney is a kidney that's lost its ability to conserve water, so water spills into the urine. That means the osmolarity will be low, usually less than 350 milliosmoles. So in summation, An intrinsically damaged kidney starts spilling both sodium and free water into the urine, leading to a high FeNA and low osms. You'll be excreting lots of salt, in other words, just not very concentrated salt. Further diagnosis of intrinsic AKI can be made by examining the sediment, which will vary from disease to disease. For example, in ATN, there are muddy brown granular casts. In AIN, white blood cell casts and eosinophiliuria. In glomerulonephritis, RBC casts and dysmorphic RBCs. This is all covered in the next few sketches, so just relax for now. And let's finish up with a brief discussion of post-renal AKI. Remember, all AKI means is that GFR is decreased, leading to a backup of BUN and creatinine in the blood. We caused this by not perfusing the kidney. That was fun. That was pre-renal AKI, if you recall. And then we busted GFR by directly damaging the kidney. Okay, so BUN and creatinine will build up. Makes sense. But post-renal? This one's interesting. By blocking the distal urinary tract, we can send pressure backwards into the tubule and block up our filtering ability. Down goes GFR and up goes BUN and creatinine. This is called post-renal azotemia. Not only that, we've made sure to illustrate the BUN bag elevated above that creatinine credit card. That means a BUN creatinine ratio above 15, just like in pre-renal. Say what? That's because all this pressure sent back to the tubule actually enhances urea reabsorption back into the serum. So your BUN can get pretty high. See how all that gross BUN bun grease is getting absorbed in his shirt there? When you think of post-renal AKI, just think of anything that can block urine flow. How about kidney stones? Well, make sure it's 2 kidney stones, 1 for each ureter. Pew pew! If only one ureter is obstructed, the other kidney takes over and GFR is maintained. What about BPH? That's a good one. At Sketchy, BPH is embodied by our hefty firefighter chief here, grabbing onto a fire pole like a massive prostate latching onto a urethra. To see what I mean, check out our urinary obstruction sketch. For now, just remember that kinda unsettling hyperplastic prostate of a hat he's got on. Looks uncomfortable, to say the least. Cancer of the urinary tract, bladder, or urethra is another concern, hence the cancer crab belt buckle right over his bladder there. Now, FeNA and UOSMs and even the BUN creatinine ratio we already mentioned aren't quite as helpful for assessing post-renal AKI. Each of these values can be pretty variable. One thing's for sure, though. If the post-renal obstruction is either really severe or prolonged, all that pressure that's sent back to the tubule starts to do some serious damage. In other words, post-renal obstruction can progress to intrinsic renal damage. At this point, you can expect lab findings similar to the ones we highlighted for intrinsic AKI. This includes an elevated FeNA, somewhere above 1%, as well as low UOSMs, and as you can see on the floor here, that BUN creatinine ratio starts to fall. And that's it. It's time to sum up this sticky AKI mess we have on our hands. First, we looked at azotemia, which is another word for BUN and creatinine building up in the serum. This occurs when GFR is reduced, either due to a prerenal, intrinsic renal, or post-renal problem. This is called prerenal, renal, and post-renal azotemia, respectively. When this azotemia is occurring in the acute setting, we call it acute kidney injury, or AKI. That's really the main thing to keep in mind here. Acute kidney injury does not necessarily mean we are directly damaging the kidney. AKI merely means that our labs have come back, telling us that GFR is diminished. Clinicians usually look at rising creatinine and low urine output. In this sketch, just look for that creatinine credit card. AKI can occur because of prerenal issues, such as hypovolemia, hemorrhage, or low cardiac output. Or it could be occurring due to some kind of post-renal problem, such as severe BPH or bilateral urinary obstruction. In the center booth, we showed how AKI can also be precipitated by direct kidney damage as well, which involves acute tubular necrosis, acute interstitial nephritis, or glomerulonephritis. The BUN creatinine ratio is elevated greater than 15 in prerenal AKI because when the kidney is hypoperfused, it starts to conserve volume. And this relies on reabsorbing urea as well, so BUN goes way up. For intrinsic AKI, the ratio is low, usually less than 10. The kidney is damaged, so it can't reabsorb urea as well. For postrenal, look for the BUN creatinine ratio to be high at first as backwards pressure makes you conserve too much urea. But then it gets lower as intrinsic damage is done to the kidney. Next, fractional excretion of sodium, or FeNA. Look for low FeNA in prerenal, usually less than 1%. We are conserving volume here, so we conserve sodium as well. In the setting of intrinsic AKI, on the other hand, FeNA is elevated greater than 2%, as the damaged kidney dumps sodium into the urine. Urine osmoles are high in prerenal, as the kidney works to concentrate the urine and conserve water. While intrinsic AKI causes low U-osms, the kidney has lost its concentrating ability, so it dumps free water into the urine. Lastly, I want to remind you that in the setting of reduced GFR, these aren't just annoying lab values we're keeping track of here. There are numerous metabolic and hemodynamic consequences of kidney dysfunction. And if the acute kidney injury is bad enough, you start to see things like hyperkalemia, acidosis, hypertension, uremia. This is all going to be covered in the Chronic Kidney Disease Dinosaur Museum sketch. Yeah, we're going full-on Jurassic Park at the end of this chapter, so get excited, because our dysfunctional kidney adventure has only just begun.